Good morning. Good morning. We're all in our places with bright, sunshiny faces. This is the way we'll start a new day. I'm Dr. Keith C. Ferdinand. I'm a cardiologist at Tulane University Heart and Vascular Institute right down the street. You pass it when you're on your way to the hotel. And this particular program is a program that's related to the heart failure in special populations, specifically African Americans. The activity is provided by the American Association of Heart Failure Nurses, AAHFN. The American Association of Heart Failure Nurses is accredited provider for continuing nursing education by the American Nursing Credentialing Centers Commission of Accreditation. And the program will give you 1.75 contact hours of continuing education through ANCC. My fellow faculty, which those who come a little bit later, I'll reintroduce when she comes to speak, but for those of you who are the early risers, is Carol Harshaw Ellis, MSN, DNP, GNP, AACNP, BC. And she explained to me what all of that means, but basically she's a nurse practitioner with specialist activities in geriatric and heart failure. Did I get that right? Carol is a cardiology nurse practitioner at the Duke University Health Systems, and she's worked in the area of heart failure and general cardiovascular care for many years. She is a consulting associate for the Duke School of Nursing and recipient of the Heart Failure Society of America Clinical Excellence in Nursing Award in 2014. Her research includes heart failure, and she's recently started a project, a nurse practitioner-led transition intervention in African Americans with systolic heart failure. Did I get that right? So we've been working closely together with you to put together a special program. And the purpose of this program is to bring to your attention some of the unique aspects of heart failure, specifically in African Americans. If I can have the first slide. My charge is to do an overview of heart failure in African Americans. You have a very beautiful booklet here. The room is a little dark because we have video that's ongoing, so they can't to keep the lighting as it is. But if you can, it may be good for you to get your booklet out and kind of flip through. In the interest of getting through this information, I'll move along quite briskly. You will have the opportunity to talk to Carol and myself immediately afterwards. I'm going to present, then I'll reintroduce Carol, she will present, and then we'll sit here at the table and have a discussion. We have cards that will be circulated. Jill is in the back. Jill, raise your hand. And she'll come through with a card. You can write down your comments and give them to her at any point, and she'll give them to us at the end of the didactic presentations. We also have stand mics where you'll be able to come to the microphone and ask a question immediately after the didactic presentations. The booklet has all of the slides in it. I think Carol may have one slide that's not in the booklet. I think all of mine are here. I looked through it. And they're very well done, very colorful. This is a keeper. You can put it on your bookcase and refer to it sometime in the future. And there will be an enduring material where you can go on the internet and send your friends for this particular purpose. Here we go. Heart failure in African Americans, here are my relationships. Carol will give you hers when she gives her presentation. I know she's has done some consultative work with Amgen. I'm going to talk about epidemiology and pathophysiology. I'm going to describe how guidelines and pharmacotherapy may be unique in this population and some of the major outcomes trials. And I would just recognize the importance, I'll do that now, of team-based care for patients with heart failure. And then Carol will take the ball and give you even more detail on how that's important in terms of these patients. We're doing better in America. Life expectancy and health and overall quality of life has improved for everyone, but not as equally in all populations. And despite these benefits, there remains a mortality gap, black versus white, which has persisted and been documented since 1960. And the large proportion of this real death gap, this is not social science, these are dead bodies at the side of the road. The largest proportion of this mortality gap is driven by cardiovascular disease. Here are life expectancy data from the National Centers for Health Statistics. At the top, you see white females, and again, longevity is increasing for all populations. But notice at the bottom, black males, a very shortened life expectancy. And even more importantly for this audience, since we have a large number of women in the audience, if you look at black females, their life expectancy is more similar to that of white males than white females, such that being a black female actually gives a shortened life expectancy. In terms of heart failure, most of you know these data. It's the #1 cause of readmission in the Medicare population. It's a major health problem. 12 to 15 million outpatient visits, and the cost in terms of dollars are noted at the top, a total of $30.7 billion. This is a report from Circulation Heart Failure published 2 years ago. And they note that of all of the cardiovascular diseases, heart failure is the disease that's actually increasing. Hence, your association and you personally are very important to the health of America. The color code is black and green. You see a disproportionately higher rate of heart failure, and you see the heart failure increasing for all populations, but a higher rate for self-identified African Americans. And the costs are going up. Hence, one of the cost-saving measures that CMS has provided is that if a person is admitted with heart failure and they come back within 30 days for any cause, they don't pay you a nickel. And that's an attempt to try to control some of these increasing in the cost of heart failure. Common diagnosis, 83% of hospitalized patients, 43% hospitalized 4 times. And the unfortunate thing is more than half of the hospitalizations are for non-cardiovascular causes, but it doesn't make a difference. If the person is readmitted for any cause, there's not going to be reimbursement. These are data from the Medicare population. At the top, you see the risk-adjusted 30-day all-cause readmission. So this is the thing that we're struggling to keep patients out of the hospital. In the middle, you see race, black versus white. And at the bottom, you see minority-serving hospitals versus non-minority-serving hospitals. So when you look at black versus whites, blacks have higher rates of readmission for acute myocardial infarction and for heart failure, and it's higher rates at minority-serving hospitals. Now, I work with the National Center for Health Statistics, and I do some work within HLBI and AHA, ACC, et cetera. And one of the things we have to struggle against is penalizing those community providers who service underserved populations because their numbers are not going to look as good. Their readmission rates are going to be higher. And the unintended consequence of penalizing these providers will be that monies are withheld for those who need it most. What causes heart failure? Well, there's a long list of causes, and I know all of you are experts in this, but specifically in African Americans, on the left side, hypertension, leading to left ventricular hypertrophy with heart failure with preserved ejection fraction and subsequently reduced ejection fraction is more common as a cause of heart failure than coronary artery disease. Does not mean that an individual who self-identifies as black cannot have coronary disease, but as a cause of heart failure, hypertension is more common. Here's some of the clinical trial evidence to support that statement. Across the top, you see the major studies. In green, you see self-identified black. First, you have heart failure caused by coronary disease, and you note that the green is less than the gray in all of these landmark trials consistently. At the bottom, you have heart failure caused by hypertension, and you notice the green bars are greater than the gray bars. So that supports the idea that heart failure, and especially in African Americans, is more predominantly caused by hypertension. Treatment of hypertension is one of the best things we can do to prevent heart failure. This is an analysis from the clinical trialists looking at over 200,000 patients. We know that heart failure reduces stroke in the gray, myocardial infarction, perhaps not as robustly because myocardial infarction is also driven by lipids, smoking, physical inactivity. But look at the effects of the appropriate treatment of heart failure. It reduces heart failure by over 50% by treating hypertension. What's unique about hypertension in African Americans and premature onset? Most of these data were first found in Louisiana, in a town called Bogalusa. The Bogalusa Heart Study looked at a biracial population in a small town across the lake from New Orleans. I was a fellow at LSU when we were doing some of this research, and it identified the early onset of not only hypertension, but atherosclerosis in youth. Increased target organ damage, left ventricular hypertrophy, heart failure, chronic kidney disease, end-stage renal disease, retinopathy. I'm from New Orleans. I'm not from where you are. I could take a poll. If you have a significant black population, and I went to your dialysis unit, I'm sure I would see a large, disproportionate group of young black people on dialysis. Much of it prevented by poor treatment of heart failure, poor treatment of hypertension and diabetes. Prevalence among the highest in the world, early onset, and higher numbers. Let's go back to heart failure. If you look at young people who have heart failure, this is racial differences in heart failure. The amount of heart failure that you see in the orange and the blue are black women and black men. These are persons younger than 40. Almost all of the instances in the cardio study were in blacks. There were some in whites, but much, much, much less. And much of this early heart failure that you see in young people, again, there may be genetic factors, but much of it's driven by poorly controlled hypertension. So to summarize, higher prevalence in African Americans, more malignant natural history, hypertension as a primary cause, endothelial dysfunction with increased oxidative stress, reduced nitric oxide bioavailability, and I have not discussed, and I'll start to discuss now, underrepresentation in morbidity and mortality trials. The heart failure starts at an earlier age. I showed you the data from the cardio study looking at persons under 40. Incidence of MI as a cause is less, higher rates of hospitalization, and higher mortality. If getting a nice Southern breakfast didn't energize you, perhaps knowing these data have energized you that this is an important place to be to talk about this subject. This is a case study, and Carol's going to take this case further and talk about team-based care in approaching this patient. This is a 54-year-old African-American male. He's a part-time construction worker. He has symptomatic heart failure, but he struggles with maintaining residence. I'm from New Orleans. I'm a deep native, many generations. We've done a wonderful job. You're going to hear about the 10-year history of Katrina, 2005, August 29th. I lost everything. I'm on my feet now. I'm doing well. But many people who don't have means, thank you, many people who don't have means are still struggling. This particular gentleman had poorly controlled hypertension, low health literacy, polysubstance abuse, and he was told his blood pressure was elevated, but he didn't want to take the medicine because of side effects. And I know you as nurse practitioners are very aware that you spend a lot of time trying to get patients to understand the need to control their risk factors. So it's a 54-year-old guy, low socioeconomic status. His BMI is in obesity range. His blood pressure has come down, but remember, once you develop systolic failure, the blood pressure becomes, quote, better because you have less forward flow and you have less of a pulsatile pressure. So it may give him the false sensation that his pressure has improved or his heart has worsened. His blood tests are listed on the right-hand side. You can see that his GFR is only a stage 2. It's probably going to get worse with time. His lipids are high. I'm not going to discuss lipids, but perhaps in the questions and answers period, we can talk a little bit about his lipids. His LDL is not optimal, and his calculated risk would be very high. His physical exam is unremarkable for acute findings. He does have some mild pedal edema and a few isolated rows. So he was given a loop diuretic. His BNP was elevated. His blood pressure now is about 143. What other medicines would you give this gentleman? What would you do to treat him, and how will team-based care affect his treatment? In addition to the diuretic and ACE inhibitor, what else would you add? Carvedilol alone? Would you add hydralazine isosorbide dinitrate alone? Would you add carvedilol and additionally hydralazine isosorbide nitrate? Or would you add an ARB to his ACE inhibitor? We don't have audience response clickers, but kind of think to yourself, what will you do next after diuretic and ACE inhibitor? The answer probably would be to add a beta blocker. Carvedilol has probably more robust data in its outcomes, US heart failure trials, than does metoprolol succinate. In metoprolol succinate, of the patients who were treated and found to have benefit, there were only a very few small number of blacks. Does not mean that the drug is not effective in a self-identified black, but carvedilol probably has a little bit more robust data. The hydralazine isosorbide dinitrate story is now in the guidelines. It's based on a trial called AAHF, and I'll show you some data on that in a second. Here's another question. So the fixed combination of isosorbide dinitrate and hydralazine has been approved by the FDA for treating heart failure in African Americans. What outcome studies were they based on? If you were listening, I gave away one part of this answer already. Is it based on the CHARM study, the SOLVE study, on target study, VHF, VHF 1 and 2, AHF, and HOPE? Number 4. VHF 1 and 2, I'll show you, and I'll show you some data from AHF. Before I do that, let me make the point that we have a very heterogeneous population in the United States. And when we have large trials and we don't include enough women, and we don't include enough self-identified blacks, Hispanics, Asians, then it's difficult to take those drugs and apply them across a mixed population and feel with great confidence we're going to get the same results. So here are blacks in some of the major heart failure trials. If you look at self-identified percentages of African Americans, you can see in some of the landmark trials it's in the single digits. At the bottom is the AHF trial, the African American heart failure trial. I was one of the principal investigators on the steering committee, and we self-identified those patients as black and included them in a trial with isosorbide dinitrate added to conventional medicine, recognizing that race is to a large extent a social construct. But I will show you that there may be some genetic underpinnings into why this particular combination was benefit in these patients. This is a very nice review paper. Those of you who get JAC, and it is noted in your slides here, you may want to look that up, because it talks about the fact that race is a social construct. To a large extent, it's a unicorn. We chase it all the time. I tried to struggle not giving too many political comments, but I have to say this is a special day because they're burying Senator Pinckney today. So we know in the United States there's a lot of impact on race that goes beyond medicine. If we look at blacks in the beta blocker trials, you can see that the percentages are dismally low. So we use carvedilol. The US carvedilol trials did show some data to support it. If you look at the Merit heart failure trial from metoprolol, the number of African Americans at the bottom is 208. Just doesn't give you the type of confidence you need that these very important life-saving medications will be effective in all populations. Bucindolol is a beta blocker which is not available. The clicker moved on faster than I wanted to because it gave you the answer. And it showed better survival in whites versus blacks. But let me show you the data to support that the blacks did not do as well with this particular beta blocker. If you look at the numbers were significant. This was an NHLBI-sponsored trial, so they did make an effort to actually include an adequate number of blacks, 627, 2,081 non-African Americans, mainly whites. And you can see that in terms of mortality, to the left side of the line of unity, which is 1, the non-African Americans had benefits with the beta blockers. The mortality trend was actually going the wrong way in African Americans. Again, I don't use these data to suggest don't use beta blockers in blacks. In fact, you should use life-saving, evidence-based therapies in all patients, regardless of whether or not they're black, white, Hispanic, Asian, whatever. But be aware that there are gaps in our evidence, there are gaps in our clinical trial basis for some of these therapies. One of the reasons blacks might not respond to beta blockers, there are some genetic studies that look at polymorphisms of the alpha and beta receptors. And with these polymorphisms, which appear to be more common in people of West African ancestry, there may be less of a benefit in blocking with beta blockers. And there are also some signaling proteins which tend to predict perhaps less of a response. This is one called GRK5, and polymorphisms of that tend to show lesser response and less protection for heart failure. This is the isosorbide dinitrate hydrolysine theory that led us to do the AHF trial. On the left-hand side, the circle you see in orange is nitric oxide synthase, and it seems to be that in some persons they have less of an ability to actually make nitric oxide, which is a vasodilating substance released by the endothelium. On the right-hand side, you see oxidase. That is something that breaks down the nitric oxide synthase. Hydrolysine has an anti-oxidase property. Now, we know it's a vasodilating, and some people have criticized the whole theory of the isosorbide dinitrate hydrolysine combination, saying you're really just talking about hemodynamics, because the isosorbide dinitrate dilates preload and afterload, so it relieves congestion. And the hydrolysine is an arterial vasodilator. Many of these patients, when you dilate them peripherally, blood pressure comes down, afterload comes down, they feel better. That being said, the hemodynamic benefits aside, the donation of nitric oxide on the left side by isosorbide dinitrate and the antioxidant property of hydrolysine was felt to be beneficial in self-identified black patients. Now, in this particular trial, what percentage of patients had as baseline 87% on an ACE or ARB, 25% on a beta blocker, no other therapy other than the fixed dose of isosorbide dinitrate and hydrolysine, or number 4, all were on an ACE, ARB, and beta blockers? What's your answer? Holler out. How many think it's 1? 87% were on ACE and ARBs. How many think it's 2? 25% were on beta blockers. How many think it's 3? They were on no other doses. The trial was just based on isosorbide. How many think it's 4? All of them were on others. It's a mixed answer. The answer is 87%. So most of them were on some blockade, either with an ACE or an ARB. About 74% were on beta blockers. They were on evidence-based therapies, although there were some gaps in the evidence I've already shown you for beta blockers. They were on evidence-based therapy, so number 3 is wrong. But it wasn't all of them. It was certain percentages. Here's the trial. 1,050 self-identified African Americans. You have to combine the ACE and ARB to get that 87%, 75% on beta blockers. And the goal was to give 2 tablets 3 times a day. The primary endpoint was a combination. 161 U.S. clinical trials. We had 2 sites here in New Orleans. It was based on a series of trials that started earlier called the VHF trials, the Veterans Heart Failure Studies. And in VHF-1, it showed that black patients tended to respond to this combination more than white patients. But look at the sample size, it's very small. Whenever you look at a clinical trial, sample sizes gives you the robustness of the data, it gives you the sense of confidence that what you're seeing actually is predictive of what's real. So this was a small sample. It should only be taken as hypothesis-driven. but it suggested the black patients responded to the isosorbide dinitrate hydralazine. And then subsequently in VHF2, looking at enalapril, the black patients did not respond as well to the enalapril, whereas the white patients had a decrease in mortality. And there are some data that ACE inhibitors are less effective in self-identified black patients. Don't use those gaps in clinical trial evidence to mean don't use ACE inhibitors or ARBs. You should, but recognize there are some data saying that the effects are not as robust. So here's the original paper, published in New England Journal of Medicine, November of 2004, late-breaking heart failure study released at the American Heart Association in New Orleans, Louisiana, 2004. The patients all had reduced ejection fractions, less than or equal to 35%, or if they were less than 45%, they had markedly dilated left ventricular end-diastolic volumes. And the endpoint, I'll give it to you because I already said it, was not just one thing, not just two things, but three. It was a combination of mortality, so there was a death, hospitalization, which is very important, and QOL is quality of life, which to the patient is probably as important as anything else. And here are the results. The combination of the hydralazine isosorbide dinitrate is in the gray. Placebo added to standard therapy, remember the patients were on standard therapy, is in the green. All-cause mortality, the p-value 0.012 was significantly lowered. There's not much we do in medicine that helps people live longer. A lot of what we do is magic. In New Orleans, we call it voodoo. But the combination of isosorbide dinitrate and hydralazine on top of conventional therapy in 1,050 self-identified black patients reduced all-cause mortality. Hospitalization was also reduced. Quality of life was also reduced. Now, those of you who are paying attention, you notice that the green bar appears to be smaller, and the gray bar, which is the hydralazine isosorbide dinitrate, appears to be bigger. But in this particular case, that was beneficial. You wanted to have it to go in that way in terms of the way they calculated quality of life. It is an improvement in quality of life. Here's the Kaplan-Meier survival curve. You want to see these curves separate whenever you're looking at a large clinical trial, and you see the risk of hospitalization is less. There's less hospitalization in the patients in the gray, the isosorbide dinitrate, and more with placebo. Genotyping, there's some signaling proteins which may be different. I told you in my opening comments that I'm going to make a few comments on genetics. There may be some signaling proteins that are more common in blacks. These are some studies that looked at self-identified blacks in AAHF, a trial called GRACE in blacks and whites. And one of those signaling proteins has a polymorphism with a TT form that's in the white bar. And you can see that particular polymorphism was more common in the black patients. And when they did an analysis within AAHF, on the right-hand side of the slide, those patients who had that TT polymorphism appeared to benefit more than those who didn't. So the self-identified race that we had in AAHF can be criticized because it's a social construct. I would accept that. But it may have been a marker for perhaps a greater tendency to respond based on some genetics which are often not tested in usual clinical care. All right, what about guidelines? As you know, everything today is based on guidelines. The first author of the update of the 2013 ACC/AHA guidelines for heart failure is Clyde Yancey. Those of you who know Dr. Yancey, he's the chief of cardiology at Northwestern, former president of the American Heart Association. But what you didn't know is he's from Louisiana, and he went to Tulane. He's a friend of mine. And what those guidelines suggest is that the numbers needed to treat for mortality and the reduction in mortality is actually quite robust with the combination of hydralazine and isosorbide dinitrate. And it is as robust, the mortality benefit is as robust as beta blockers, aldosterone antagonists, especially in patients with more severe heart failure, and ACE inhibitors, which should be utilized, but perhaps doesn't even have as robust a data set. and you see the numbers needed to treat was only 7, meaning that if you have a population for 3 years and you treat them, then 1 out of 7 of those patients will be beneficial. Here are the guidelines, Class 1A, the combination of hydrolyzed and isosorbide nitrate, heart failure, who have symptomatic heart failure, and they're on guideline-directed medical therapy, meaning that they're on an ACE or they're on other medications. And this is the way we now approach the treatment of heart failure. We give beta blockers added to ACE or ARBs. Diuretics is needed, although there's no evidence diuretics help people live longer. You give them for symptoms. And in self-identified Black patients, based on the guidelines, the combination of the fixed dose of isosorbide dinitrate. Carol's going to bring home the message that we need to reduce some of these disparities. She's going to talk about some things. We're not going to go into all of this. Provide awareness, we're doing that. Expanding health insurance, the Supreme Court said that's a good thing. Increasing the number and capacity of providers in underserved communities, hopefully some of you are going back to those communities, and increasing knowledge about disparities, we're doing that. So in summary, genetic ancestry may play some of the components as it relates to heart failure. We know that race, skin, racism, poverty, all of these things have effects. They're hard to measure, but we still need to explore physiologic changes and get appropriate subpopulations in our studies. The BEST trial, remember the Bucindolol trial, suggested that efficacy in non-Blacks does not necessarily mean the same efficacy or safety in Blacks. And the AAHF trial, which I've shown you in some detail, suggests that there can be significant benefits with isosorbide dinitrate and hydrolysine plus conventional therapy. The next presentation, and then we'll have time for questions and answers, will be Carol Harshart-Ellis. Those of you who just came in, she's MSN, DNP, GNP, AACNP, BC. I didn't know what all that meant. She explained it to me. I mean, she's a nurse practitioner who also specializes in geriatrics and heart failure, and she's from the Duke Division of Cardiology, Advanced Heart Failure. Carol.
Good morning. Thank you to our sponsors. So the title of my talk is Health Disparities in Team-Based Collaborative Care in Heart Failure. As you notice, the team who won the national championship. These are my disclosures. So how do we define health disparities? The Institute of Medicine, I feel, did it best. Racial or ethnic differences in the quality of health care that are not due to access-related factors, clinical needs, preferences, and appropriateness of intervention. Why is it important? I think Mead said it best, and colleagues, beyond the moral and ethical dilemmas posed by inequities in health outcomes, there will likely be an increase in the number of individuals at risk for disease, shorter life expectancies, poor quality of life, and health care as proportions of the minority population continue to grow. And in fact, the US Census Bureau projected the change in racial ethnic differences. In 2000, 69% of the US population was primarily white. By 2015, it is projected that 50% of the US population will be minorities, with the Hispanic population almost doubling at 24%. So there's always been a little controversy about whether health disparities exist. And in 2008, PBS ran a series, Unnatural Causes, Is Inequality Making Us Sick? And so what they did was, it was a 4-part series, each having 2 sections to it. One of the sessions was health and wealth. It focused on Blacks living in impoverished and being disenfranchised communities, where they would live in communities with chemical plants and they had a higher risk of cancer and respiratory illnesses. Also, when the bow breaks. Infant mortality is the pulse of a population. And so in the United States, Afro-American women are 3 times more likely to have high infant mortality rates than whites with a high school diploma. Now, education and income are often the determinants, but not in the Afro-American women in this country. And in fact, 3 times higher is even higher than that of African women. So that's very important to note. Also, they did bad sugar. Minority populations living in communities where they live in food deserts, which are high sugar, processed, high carb foods is their only access. They also live in communities where they can't even afford a PE teacher, so the children don't even get PE. And then there's also communities in California, Richmond, California, they did a special on, which young men discuss what they're going to be buried in because of the violence. They don't expect that they'll live beyond 20 years old, instead of talking about what they'll wear to the prom or even at graduation. So when we look at the disparities as far as cardiac care, 81 studies were evaluated. They were peer-reviewed, and most were methodologically sound. 68 studies found racial and ethnic differences. Of that group, 48 found differences in procedures as well as tests. And in 11 studies, they found no racial and ethnic differences in care. In 2 studies, they actually found that minority groups more likely than whites to get the appropriate care. So this, you've probably seen it in a lot of different ways, but Schulman and colleagues looked at hypothetical patients, 720 physicians, and everything was the same except for race and sex. And what they found was that women and blacks were less likely to be referred for cardiac catheterization than men and whites. So the bottom line is black men and women are more likely to die from heart disease than all other racial and ethnic groups. So in this era of healthcare reform, and we're trying to reduce readmissions, health disparities have become very important because, as you can see, non-Hispanic blacks have a higher rate of potentially preventable hospitalizations, and close behind them is Hispanics. So you know who to focus your interventions on. Black men and women are most likely to have heart failure. It's already been shown in Dr. Fernandez's talk. High blood pressure, stroke, and black women are more likely than other women to have coronary artery disease. So Afro-Americans and heart failure, this has already been discussed, but I'll highlight. They have a higher incident. Cardiac resynchronization and defibrillators are underutilized, but this has improved. My colleague, Dr. Al-Khatib, has actually shown that. They're 20 times more likely to develop heart failure before the age of 50, and they have a greater chance of death and reduced functional status. So when we think about health disparities and do they exist, you also have to look at perceptions. So in this particular survey, they surveyed 344 cardiologists, and they asked them what they felt contributed to healthcare and the differences in racial and ethnic groups. Well, most of them felt there were psychosocial issues. So as you can see, differences by cause, 69% felt it was from insurance, 56% language barriers, 47% felt it was education. But when you look actually at differences by race alone, that number goes way down. The perception is that, at least in cardiac care, was due to 33%. And as it gets closer to the provider, the number gets less. So in their institution, they felt 12%, and in their actual practice, it dropped to 5%. So you not only have to look at the provider's perception, but look at the patient's perception. When they come to you, they don't just drop their life experiences and their beliefs and a lot of the things that they believe. You have to consider that. And while they don't talk about it, these are the things that's being discussed many times in the home as well as in their communities. We're all familiar with bad blood, or the Tuskegee syphilis experiment that ran from 1932 to 1970, where black men were improperly treated with syphilis. So sadly enough, that lasted for about 40 years. In exchange, they were given free meals, health care, and burial insurance. And then Henrietta Lack. How many have heard of her? The immortal life of Henrietta Lack. She was a tobacco farmer. She got her care at Hopkins. She had cervical cancer. They took her cells without her consent. And unknowingly, her cells actually progressed medicine tremendously. Polio, gene mapping, vitro fertilization. And so if you would take these cells and wrap them around the earth 3 times is how many cells there are. They still exist today. And finally, the AIDS conspiracy. How many of you have heard of this? It was done in California. It was a telephone survey randomly of 19,000 numbers. 500 answered the question. They asked them about AIDS, and blacks felt that it was a conspiracy. About 48%, almost half of them felt it was a conspiracy. More than half felt that it actually was created to kill or the genocide of the Afro-American community. So these are the things that is being talked about. And while you may not be aware of it, the black communities are. Black Lives Matter. So if you have a TV, you have a newspaper, this movement has been big, particularly over the last year, about the shooting of unarmed black men. And so while you see it on TV, and it's a lot of political, it certainly also is in your office. Because remember, this is all about perception. So this also talks to trust and mistrust of the healthcare system, but it's a challenge to medical and public health communities. The University of Vermont, Dr. Bassett did a talk, and she actually mentioned Eric Garner in her talk. And so the medical students wanted to know what they could do to actually speak out against some of the issues about racism. And so they had a white coat die-in, is what it was called. But even with that, they wanted to do more because their question was what they could do to reduce racism in institutions and interpersonally in the patients that they take care of. So when we look at patient-centeredness, blacks and Hispanics are less likely to report confidence and trust in their specialty, heart failure, than whites. That's important for you to know. Also, Hispanics are twice as likely as whites to leave the doctor's office with unanswered questions. This could certainly be due to language, but the Common Wealth Fund, it was a telephone survey of over 6,000 people, and so this is what they found. Asian and Hispanics are less likely to understand their doctor and less likely to feel that they listen to them than whites and blacks. So the Institute of Medicine in 2002, Dr. Alan Nelson, who was a retired physician and head of the American Medical Association at the time, said disparities in healthcare delivered to racial and ethnic minorities are real and are associated with worst outcomes in many cases, which is unacceptable. And then the Institution of Medicine followed up with that. The real challenge lies not in debating whether disparities exist, because the evidence is overwhelming, but developing, implementing strategies to reduce and eliminate them. So there's a lot of theories as to why health disparities exist. I like the perspective from Health Services Research. They think that it's a number of things. It can be due to clinical encounters, patient factors, and providers factors. Well, we've covered a lot of the patient factors, beliefs and preferences, race and ethnic culture and family context. I always tell people there's some things my grandmother told me when I was growing up, doesn't make sense. I can't prove it scientifically, but I believe it. So this is some of the same things that your patients deal with. Education and resources, and certainly biological, which has already been touched on this morning as well. You also have to look at provider factors. The knowledge and attitude, we all come with our own biases and our own beliefs. Competing demands, some things that are in your organizations structurally that you can't necessarily control, that you may distract from you being able to take care of your patient. I know we did implementation of Epic. That's still a distraction from the provider. And the clinical encounter itself, how the provider communicates, clinical competency. I'm sure all of us undergo that clinical competency every year on the computer, and we pass the test. But I'm not so sure that's the best way that we should do it. But they didn't ask me. So Robert Wood Johnson has done a lot of work as far as disparities. And so what their recommendation is as far as to reduce health disparities, at the top you'll see at the yellow box, team-based care. It also should include multifaceted programs, culturally targeting, patient navigators, and interactive education. So how is it defined? Naylor and colleagues defined team-based care, and I'll highlight some of the main issues. Comprehensive, to individuals, families, and/or their communities by at least 2 healthcare professionals working collaboratively with patients, families, caregivers, and community service providers on shared goals across settings to achieve care that is safe, effective, patient-centered, timely, efficient, and equitable. So I included some of these slides, and this is, the reference was cut off, but this is by Mitchell and colleagues. What the important things for your team, you have to have shared goals. Everybody on your team has to know what the goals are, and you also have to have a way to measure them. And that's important, because if you're going through the motion every day, you want to give your team some feedback. You also want to make sure there's mutual trust. This is the part I struggle with. If I give, let's say, the medical assistant a task to do, I have to trust that she's going to be able to do that. Sometimes, oh, did you call? Did you do it? And so that really takes away from your team. You have to really trust people that they're competent to do what you've asked them to do. And also effective communication. There also has to be clear roles. There's some overlap, but everybody has to have a defined role so they can feel a sense of accomplishment as to what they're doing. Now, this is some of the things we learned in elementary school, but I think you have to lay the ground rules and what the expectations of everyone on your team. Honesty, that's very important. Humility, particularly working with minority communities. You have to have a sense of humility in working with them, and even humbleness. Discipline, you have to you want somebody on your team that's creative and curious, somebody who can think outside the box. Because team-based care, we don't know what elements are actually of it make the most sense or what has the best outcomes. But you want somebody on your team who can think about these things, even somebody maybe that represents those communities, that has ideas about what you can do better. And so team-based care is endorsed by a lot of experts and professional organizations. The American Heart Association actually backs the taxonomy of the disease management in team-based care, as well as the Disease Management Association of America. And they also feel like it should have some component of Ed Wagner's and colleagues' chronic care model. So who is on your team? I think it's important, and I put this in here, because sometimes we think of just the medical team or the medical part, but you also have to include the front desk. You have to include the transporters. It's important to have them on your team. In our clinic, the heart failure clinic sits in the very back of the clinic. Now, most heart failure patients can't walk that far. So we had to actually meet with the transporters and team and let them feel that they're a part of our team, so that when we call them to get a patient, they feel a sense of connection. And so they get to know the patients over time, and they're very receptive and want to participate. So you have to include everyone on your team, and particularly the patient and family. Don't forget they're a part of the team as well. So your partners or collaborators may not look like this. In our institution, primary care, that's a big thing with chronic care management, with transitions in care. You want specialists. We work a lot with palliative care and, of course, electrophysiology, infusion companies, home health, and community resources, which are very important. You need to know what services are available. So what are some strategies that are promising just regarding health disparities? Well, what has been shown, and this is by Marshall and colleagues, that multifactorial interventions that address at multiple levels of change, culturally tailored quality improvement, and nurse-led interventions within the context of wider system change. This is REACH 2010. How many of you have heard of REACH 2010? So this was actually sponsored by the CDC. I could not put everything on here, but if you haven't read it, it's just incomprehensible to me. It focused not necessarily on heart failure, but it did on diabetes, hypertension, HIV, AIDS, breast cancer. But what they did was they took a lot of the organizations involved, civic organizations, libraries, professional organizations, fraternities, government and businesses, local media, and they actually helped with the intervention implementation. And so some of the things that they looked at was patient education, just empowering the patients. They used community health workers in some of their interventions. They used coalition building and advocacy. They went to the providers. They did some audits as well as feedback. They developed patient registries. They did continuous quality improvement. And so all of these led to better outcomes. If you look at it, the amount of hemoglobin A1Cs that were out of proportion or elevated was something like over 12,000, and those came down by 80%. It's really impressive. And this is continuing on. The CDC is still sponsoring some of this. And so I included this. Most people, are you aware of Expecting Success by Robert Wood Johnson in Cardiac Care? This was done specific for health disparities. I know my institution participated in it. It ran from 2004 to 2008. And what they found was they improved the institutionalized collection of self-reported race, ethnicity, and language. And they improved the quality of care. They provided a model for the use of performance data that's stratified by race and ethnicity. And within 1 year, every hospital increased its percentage of the core measures. And core measures was important at that time for heart attack and heart failure. So we also have some nursing interventions. Everybody's probably familiar with Naylor and colleagues and her transitional care model. It was led by advanced practice nurses that started in the hospital and then followed the patients to home. They did directed discharge planning, home follow-up. They had protocols for care management and individualized care plans. But this also had a multidisciplinary team. You may not be aware of that, but they used pharmacists. They had access to social workers. And so they had access to other disciplines, even in this intervention. And so what it showed was 36% reduction in rehospitalization as well as reduced costs. So on average, about $5,000 was saved for each patient. Sokowski and colleagues, they actually looked at 10 clinical trials. They looked at the chronic care management of heart failure and which interventions had the best outcomes. And so they found that if you utilize a multidisciplinary team approach and in-person communication, that these are the ones that had the best outcomes as far as reducing readmissions. And then Holland and colleagues looked at 74 clinical trials that were randomized. And they looked at the interventions that were best for heart failure. They found that multidisciplinary interventions that had at least, that included medical, as well as one or more disciplines, reduced readmission, but also reduced overall mortality, which was statistically significant. So this takes us to the case study. It's still this 54-year-old gentleman. I'm just going to highlight some things. He is a construction worker. He came in with symptomatic heart failure. He struggles with maintaining residency intermittently, presented to the ED with acute onset heart failure symptoms, shortness of breath, orthopnea, early satiety, treated with IV Lasix. They titrated his evidence-based therapies. And the important thing about his lab values, remember he had a history of polysubstance abuse. His drug screen was positive for cocaine. If you look at his cardiac index, it was 1.3, but because of his psychosocial situation, he's not a candidate for advanced heart therapies. Past medical history, hypertension, which we've already talked about, is very common, polysubstance abuse, low health literacy, and he was uninsured at the time. So how can a team-based care benefit this patient? This is certainly not all-inclusive, but these questions are to begin to get you thinking about team-based care and patients, particularly in minority populations. So who are the multidisciplinary team members? Who should be on the team? What community resources are available? What about the patient and family as team members? What partnerships should be evaluated? What are some important cultural aspects to consider? And what can we do to think outside the box? Remember that team member that was curious and creative? So this is maybe what it would look like. On the left, you have the team members, physician and nurse practitioners. It could also be a physician assistant. They would do the visits. In our clinic, we have clinic nurses and we have nurse clinicians. Their roles vary by medications. They do refills. They do our forms with disability forms, telephone follow-up. We have medical assistants. So they do a lot with patient flow and running the clinic and making sure patients are in rooms, and they keep the flow going, as well as things such as vaccines. They do some triaging. And our social worker helps with meds, meal referrals. She gives like meal tickets to the patients when they come, particularly this gentleman who would not have income for food sometimes. She'd help with transportation. And we'd also get palliative care involved to talk with him about advanced life decisions. In the community, we have a free clinic that was started by a nurse and her sister. It's totally free. It's all grant funding. So this gentleman would be an excellent referral for him. Substance abuse counselors is also within that free clinic. It's offered as a service. faith-based. And getting to know this gentleman, we knew that he was, had a strong tie with faith and his religion, looking at social services, getting him to apply for Medicaid or disability, and a library. Remember, we said he was health illiterate. We have reading programs in our communities that are free. And so he also, during the process of his care for heart failure, he learned how to read. So think outside the box. We contacted his brother and other siblings. He had 4 in all. And they did not live in the immediate area, but his uncle did. And he was very involved in his care. And so he was very helpful in that as well. In our pharmacy, patients who are uninsured get a 30-day supply of medicines free. And as long as they don't have insurance, they get their free medicine. So each month, he would come and get his medicines. And so that continues, and I guess as long as the money doesn't run out, and it hasn't so far. Our primary care, they have resources. They have case managers. They have free or reduced fees for these type patients and other special programs that would benefit him. Resources, free scales. We work with the WellFlix video. We're doing a pilot program. So we have a same-day access clinic with chairs and a TV. So remember, he can't read, so he can go in and watch these videos. And so that helps us a great deal. Housing for Hope, we have a resource that helps people with housing or transient housing and multidisciplinary rounds. So his plan of care, instruct him how to weigh himself daily. So we gave him the free scales. They're talking, they're lightweight because he has to carry them around. As I've already alluded to, have him watch the heart failure videos. We gave him handouts with pictures on his symptoms and when to call. We provide him with a phone number and pager. With Medicaid in our state, they get a phone with 250 minutes, so he could use that phone. Same-day appointment. He never knows where he's going to be or when, so he could walk in just for an appointment. Teach other organizations that he'd come in contact with to be creative as well. Remember, we said faith-based organizations? So we teach them about rinsing canned foods. It doesn't cost them a whole lot more, or trying to purchase the no salt, which is a little more expensive. But these are things that you can be proactive about in your different communities. Go shopping with him. He shops in food deserts. Most of his food came from the dollar store. So we'd go with him and see what the best choices are for where he shops, and also make some other suggestions. And help with coordinating his appointments, because remember, he can't read. It's very difficult to navigate the healthcare system, as we all know. And if you can't read and you have some other psychosocial challenges, it makes it even more difficult. So in summary, health disparities exist and persist in the United States. Team-based care shows its promise as an intervention in heart failure as well as health disparities. There's a need for well-designed studies, and qualitative over quantitative have actually shown more promise, and participatory research seems to be the most appropriate methods. We need better diffusion of innovations. It is unclear what type of teams and the aspects of the models are most effective. Thank you.
You can write down some questions on cards or a piece of paper and bring them to them, and you can go to the mics in the middle. While I'm reading this first question, I'm going to ask Carol a question. Did you have social service work with this guy in terms of trying to get him food stamps or some other assistance?
So we did, but food stamps, you need an address. So that was the challenging part. So we had to look to other community resources for that, like I had alluded to with, they have mobile food vendors, which is free, as well as faith-based organizations. But if you don't have an address, you can't get food stamps.
Anybody's going to come to the mic, or y'all shy? All right, there's a comment and a question built in here. Despite the scientific overwhelming evidence of the fixed-dose combination isosorbate and nitrihydrolazine, and as well as the fact that it's a 1A in the ACCHA guidelines, this therapy is still underutilized in our clinic. And it's not just your clinic, it's across the country. Remember, there are no data on the individual components, yet that is used in African American patients. Why? The individual components may have benefit. Jay Cohn, who's at the University of Minnesota, he was one of the pioneers of heart failure therapy. He worked early with the VHF trials. He also worked with some of the ACE inhibitor trials. He's the one that suggested that based on some studies he had done in the lab, that you have to mix the isosorbide and the hydralazine at various dosages in order to balance what he thought were the effects with nitric oxide availability and the antioxidant availability. It also may be related to the ability to vasodilate, so I'm not dismissing the hemodynamic component. If you can't get the fixed dose combination, then I think it is reasonable to try to get some sort of nitric oxide donation plus vasodilatation antioxidant together. The FDA actually does suggest, however, that there is no substitute for the fixed dose combination, but money is real in the United States as it relates to healthcare, so that becomes a big barrier. And I think something is better than nothing, but the data are not robust that you can just mix and match and get the same benefit of side effects. Question? Comment? Oh, come on, y'all. Somebody's going to the mic. Yes.
Mike. Hello. I recently had a young woman who had a postpartum cardiomyopathy and faced a lot of these challenges with being her second pregnancy and problems with trust and substance abuse and multiple issues. I live in Cooperstown, New York, which is as white an area as you could imagine in upstate New York. How do I, as a white practitioner, first of all, deal with that? I mean, it's like trying to elicit some trust with this young woman. And then I have just a second question about problems with her blood pressure, that favoring ACE therapy over isosorbide and hydralazine. Which would I mean, I kind of went with the isodil hydralazine combo in favor of the ACE, but wasn't sure if that was the right thing to do. So, comments about that.
You want to talk about the team that could help her? What was her self-identified race, ethnicity?
So she was African American.
Okay.
Okay. And as you know, this is a challenge for caring for people sometimes that don't look like you and building trust. One thing that I stress to people, even my own institution, that sometimes I'll raise issues. I'm one of those people that will push the card, and I'll raise the issue about care and why it's different. And so many colleagues will say, you know, I'm colorblind. You know, I don't see color. And so that's an issue. You need to be color sensitive, but not colorblind, because we're different. And as you've seen the data, that you do treat people differently. And so one thing that I would recommend that we often do is, what is their culture? Do they have a strong faith-based community? Myself, and I have a very good friend of 30 years, and she's white. We actually go around to churches together, and we do presentations on heart failure and palliative care. And so you want to know what you have available to you for resources, and, you know, be honest. That's the important thing that they're looking to you for, and you have to build a relationship in order to build trust.
Yeah, I'm going to give just a little response to that because Carol's the expert in team-based care. I think it's important, no matter how busy you are, to sit down in a chair, eye level, talk to the patient and touch the patient. At Tulane, we have ECW, and I also have Epic at one of the hospitals here. And although I'm an older guy, I'm computer literate, but I refuse to sit in the room with my back or my side looking in the computer talking to the patient. The patient's the only. Now, in terms of the specific therapy, as you have hinted, the data in terms of the blood pressure effects and the heart failure effects with ACE inhibitors are not as robust as seen in the general population. Some of that's driven by sample size. Some of it may be driven by the fact that volume-dependent blood pressure tends to respond less to the RAS-blocking agents, whereas diuretics and long-acting calcium channel blockers do a little bit better. Now, once the person develops heart failure with reduced ejection fraction, the calcium channel blockers are relatively contraindicated. Verapamil, diltiazem are clearly contraindicated, but even amlodipine, although there's no true contraindication, may be less effective for heart failure. So I still would use an ACE or an ARB, You'd have to choose which one, make sure it's long-acting and works. You're probably going to have to add a diuretic to it. And in that particular case, because if the patient has reduced ejection fraction, the vasodilating drugs, the isosorbate hydralazine, may actually also help to unload the heart, and it does have a blood pressure benefit. Carvedilol, as I've shown my hand, I think has a little bit more data in the U.S. Carvedilol trials than did the Merit Heart Failure trial, which only had 2,008 African Americans. Plus, Carvedilol has alpha-blocking properties, so it tends to have some more of an afterload reducing effect if the patient maintains a blood pressure. And some African Americans, for some reason, can maintain very robust blood pressure elevation even with reduced ejection fraction. I think Carvedilol might have a little leg up on long-acting metoprolol in those patients. So it takes a lot. It really does. Medicine is not easy. And that is probably some of the disparities we see, is that the clinicians don't take the time to educate themselves and don't take the time to be more culturally competent, which is a catchword. It just means that you're not sensitive to some of these nuances in how patients present and communicate with patients effectively. It's difficult, but if we don't do it, we can continue to waste money, we're going to continue to have rehospitalization, and we're going to continue to have that mortality gap. And the people around the world, you know, we listen to ourselves too much, how great a country we are. We're number one, we're number one. The people around the world know that our health care here has some big gaps. They know about disparities. They know that we only have the 16th longest mortality in advanced countries. So don't fool yourself watching television in the United States, you know, we're number one, we're number one. People elsewhere, in fact, a Danish physician just told me 2 weeks ago at the American, I go to all these doggone conventions, where was I? But the Danes and the Swedes, they were very prominent. If you have any friends who are from there, you can ask them. They'll very prominently tell you that everybody has health care, and you can go to the doctor anytime, etc. They know. They know that they have a superior health care system. The Japanese do also. Anyone here who's of Japanese extraction, if you live in Tokyo or Kyoto, Nagasaki, and you want to go to the doctor today, you just get up and go to the doctor. They don't even understand this idea that if a person doesn't have insurance, they can't go to the doctor, or they're called self-pay, which I'm on the board of one of the hospitals here. I call it no pay because people can't pay for that stuff. Comments? Come on, y'all. We actually stopped. You want to go back and give some more lecture?
Oh, I can.
Yeah, what town are you in? What town are you in? St. Augustine, Florida. She was saying that she works with patients who've been marginalized. Many of them are homeless. And for instance, there's a rainstorm, the house floods, they don't have ID. You can't get social services. You can't get continuing access to care. Even the free clinics will tell you, you have to go get ID. But they don't have anything no birth certificate, no driver's license, nothing. What can we do?
That's a hard question. It works different where I'm from. That free clinic that I alluded to was actually started by a nurse and her sister, and they don't ask a whole lot of questions. They're there just to help them, and so they serve them. They don't have to present an ID in order to get help, so that's quite different. But we do have Housing for New Hope, and it is a nurse who particularly worked with homeless. She goes under bridges and different things and works with them, and so she works with them to get the things that they need. So I don't know in your particular community, I don't know if you've looked at what's available, what's not available, but we see that a lot. A lot of people come to our town to bury their mother and don't have money to get back from where they, and end up homeless. So we do see that, but because it's so large in our area, they put things in place, and maybe you can be an advocate for that.
Well, similar to what I asked Carol about the case that we presented, did she get social services involved? Social services got to really help you there. And I'm going to make a comment about Hispanics, Latinos, and identification after we take this question. And it's an important comment I'm going to make. Yes?
No question, just a comment.
Comments are fine.
I'm from San Bernardino County in Southern California.
What county are you in?
San Bernardino County. San Bernardino County.
San
Riverside,
Bernardino?
Inland Empire, Southern California.
You ever heard of Stronger Heart?
Yes.
You know National Forum for Heart Disease and Stroke Prevention?
Yes, my hospital is a member.
All right, go ahead. What's your
We're active in
comment?
that. Anyway,
I'm just showing you, I'm from New Orleans, but I know San Bernardino too.
very poor county. In my master's nursing program, I was in the population-based program, focus on that. And the faith-based community was very, we tapped into that quite a bit in establishing clinics and health fairs and free clinics and that. But one thing we did, my BFF in the nursing program was African American. We went to the beauty shops. She went to her particular beauty shop because the ladies are there all day long. You know, they're a captured audience, and we did hypertension clinics. We did many health fairs at the beauty shop. I mean, they're a captured audience. They're there all day for their weaves or whatever. Yeah, so the faith-based community was very active and supported us with monies and support our health fairs and that, but we got a lot of bang for our buck at the beauty shops. I didn't know if you had ever tapped into that, but it's very successful.
Very good comment. And not only a very good comment, I'm going to extend on San Bernardino County. It's the largest county in the United States if you take out the Yukon in Alaska, which is not actually incorporated. And it has a high rate of patients who are undocumented immigrants and people who live in poverty. It's a racially mixed county, and it is a county that has embraced using their 211 system, which you have 911 for emergencies, and that's just not a good way for patients who have chronic needs every time they need something called 911, because the 911 emergency is they're going to just say, we'll send in, the EMTs, or we send in the police, or we send in the fire truck. That's not the answer. They're using some other ways to try to get patients to services they can call the 211 number. So please continue to develop what you're doing in San Bernardino County. My comment on Hispanics, Mexican Americans, if you look at blood pressure control and you look at use of evidence-based therapies, it's the lowest in that population. And one of the reasons it's low is not necessarily that they have some of the severe levels of hypertension, heart failure you see in blacks, but they have less health-seeking behavior because many of them are undocumented, or many of them are afraid, even if they're documented, that they're going to be judged as undocumented, or the family member who comes with them may be undocumented. So I would hope, and I see we have a very sensitive and knowledgeable audience here, that if your hospital is laying the hammer down on people when they come in, that they show their papers, tell them, hey, it may not be the best thing, because if they don't come in for care, they're all going to come back, but they're going to come back in acute heart failure or end-stage renal disease or with metastatic cancer, and then we're going to be caught with this big bill, this big money outlay in a person who doesn't have any insurance. So the best thing would be to treat people regardless of whatever evidence they can show for residency or citizenship, because if you don't treat them, they're coming back anyway, but they're going to come back when they're much sicker and the cost is going to be much higher. And that's just my personal opinion. Your county or your hospital can continue to do what they're doing, but I don't think it makes sense to lay the hammer of the law on these patients when they come in for care.
That's true. I just want to make a comment about the beauty shop. One, you're talking about culture that we do as Afro-American women stay in beauty shops for a long time. But this actually is published at barbershops for men. Men are often very resistant to going to the doctor. And so there is a study out of Maryland that looked at providing some of this care as far as hypertension and monitoring blood pressures in the barbershop. And we've done some of that in our area and health education as well. So don't forget about men because sometimes they're the most challenging to reach.
If you want more information on the San Bernardino, you can go to the National Forum for Heart Disease and Stroke Prevention website. Comments? We have a few more minutes. Yes.
We battle cocaine in our community and alcohol in our community. We have a huge wealth disparity, very wealthy.
Where are you from?
St. Pete, Florida.
Yeah.
Hospital's right across the street from a homeless encampment.
Yep.
And I'm grateful to work there, by the way. But my question is, what are we doing to educate our communities about the effects of cocaine on their heart? We tell them, no, don't do it, and do our little education in the hospital, but what campaigns are we creating?
So that is something near and dear to my heart, as 40% of the population that I serve has drug addiction. And in fact, it used to be crack cocaine, but that has become too expensive, so now heroin is the drug of choice, it's cheaper. And so one of the things that we have done with our social work is that as part of the heart failure clinic, we have substance abuse counselors that are available, and the patient, and they get special preference, and so they get a number that they can actually call. But as we all know, that it's not just with healthcare, it's a larger societal thing. And I said, you know, people know about smoking. I don't know if you all, they show that lady that gets up and puts her wig on and puts her trach on. We need something, a commercial for heart failure that people just don't believe it. You know, I've struggled with some people with cocaine. I said, you know, one gentleman said, I'm not like a drug addict, you know, I just do it once a week. And so their whole perception is quite different. And so we do need a campaign, a commercial, because they don't often get the connection between heart failure and drug use.
Yeah, I have a medical question on the isosorbide mononitrate. Is it as effective as the dianitrate? You know, it's better than nothing, but remember the study used the dianitrate, and it uses it 3 times a day in combination with the hydralazine. So if you're using the isosorbide mononitrate, I would not say that that's adverse, but it's not the guideline-based therapy. It's not what's in the ACCHA guidelines, and it's not what was used in AHF. But I'm certainly not making the case, therefore don't use anything. We have to use something in the place. In terms of hypertension, let me go back to a comment I made about the ACE and the ARBs as being less effective. That's as monotherapy, but in patients who self-identify as black, especially who have low renin volume-dependent hypertension, you can add to the ACE or the ARB a long-acting diuretic or long-acting calcium blocker, and that tends to blunt or ameliorate the decreased response that you have with those agents. But just be aware of the fact that there may be less of a response. You want to say anything about drugs?
I have one question. We were going to talk about the lipids.
Yeah, thank you. That's why I like Carol so much. That patient had an LDL of 130. If you do the ACCH risk calculator, his risk was 10%, which is very high. Anything over 7.5% of dying or having a major event is high, and his lifetime risk is over 50%. So he's still at risk for vascular disease. Unfortunately, when you look at patients who have heart failure with reduced ejection fraction, that overwhelms their death mortality. They have a mortality 50% over 2 years. So there's less robust data that treating his lipids would help him live longer. That being said, when you go to a good practitioner like Carol, she may be able to evaluate him and treat him appropriately for his heart failure and get the social services and the diet. I would still treat his lipids, because in that particular case, you don't want him to survive from the heart failure, have an improvement in his ejection fraction, an improvement in his quality of life, and then have a massive heart attack because you didn't treat his lipids. I would treat his lipids. The data with statins is underrepresented in blacks. I could do the same lecture for statin therapy. The first big trial was the 4S trial, the Scandinavian survival simvastatin trial that was done where? Scandinavia. The next big trial was the West of Scotland trial with pravastatin that was done in the west of Scotland. So most of the trials started in Europe, and even in the United States, the blacks were underrepresented in these trials. But I don't use that to mean, therefore, don't use statins in blacks. I would still place this guy on a statin. I would be careful with interactions which statin I choose, but I would still treat his lipids. But this wasn't a lipid forum, so I didn't go into it. One last question, a great question. Someone's going to ask the last question, then we're going to thank you for attendance. One more question? Go. All right, Carol's going to give you the last comment on what she does in the difficult-to-follow patient, and then I'm going to close.
So we have about 20% of our patients are no-shows, but we actually looked at that. And so you want to look and see why. We found that the inability for the copay was a big thing in transportation. So we do give a lot of free bus passes. I have a stack in my office. They have to pay to park, so we give free parking to get them there. And as of July, we've launched a home program where myself and the other nurse practitioner will be going in the home to see those particular patients, because those are the ones that are usually highest risk. And so I would just strongly suggest that you look as to why they're not coming, because usually there's a reason. Even in young women, we found that they didn't want to bring their children, and so some of the medical assistants are good babysitters as well. So try to drill down as to why they're not coming.
All right, I want to thank you for attending. Those of you who came a little late, we did mention this is an accredited program for 1.75 contact hours, and both Carol and I did have our disclosures on slides, and they are in the brochure. Thank you for attending.